Good morning. We're going to go ahead and get started. I'd like to welcome you to our conference today. We're so glad that you're here. My name is Gail Hillicky, and I'm the director of Kentucky Campus Compact. We're an organization that promotes civic engagement and helping colleges and universities around the state live out their public purpose. So we're thrilled to be part of this conference as one of our priorities is community impact. And the work that you are all doing and that we're going to be doing today certainly has that effect on the community. First, I'd like to start out and see if there's any veterans in the audience that we can recognize today on Veterans Day. Can I see any veterans here? So we've got a couple. Let's thank you for their service. We're glad that you're here on Veterans Day, and this is a great way to honor those who have served and are serving. So today we're really going to focus on learning about neonatal abstinence syndrome. We're going to hear from many speakers who have thought deeply about this topic and have done research and are doing practice, medical practice around this. And we're really hoping that one of our goals today is that you leave here more informed and inspired to continue doing the work that you're doing, or maybe partnering with someone new about this work. And then our other goal today is for us all to think about how we can collaborate to address this opioid epidemic that we're facing. So together, we can do so much more than we can individually. And that is the purpose of this idea of a consortium that you'll hear more about during the day today. How can we find what research is already going on, find out what the gaps are, and work together to close those gaps and help folks in the community really use evidence-based practice for our work. So we're glad you're here. We really want you to think a lot about this work today and get to know each other and build those collaborations and networks. I'm going to start today by introducing our person who's going to welcome our keynote speaker. And this is an individual who has been at Northern Kentucky University since 1999. He's served many different roles as Dean of the Chase College of Law. He's been a professor, and he's been a vice president of university advancement. And most recently, he's been our interim president and has served us well. But I'd like to please help me welcome Jerry St. Amand.
Well, thank you, Gail, and good morning, everyone. It's great to have you here at Northern Kentucky University. I tell you, I looked around, and the last count I saw, we were getting close to 200 people here, and from 20 different colleges and universities, from multiple healthcare provider organizations, from social service organizations, from law enforcement, elementary and secondary education. We have representatives from the Kentucky Governor's Office, from the Ohio Governor's Office, and when you look at all of those together, combined, you know, people here from 7 different states. And so it's just wonderful to see this level of not only interest in, but commitment to trying to accomplish something very important. That is trying to translate research into action to try to solve, you know, a very critical problem that we're confronting in our nation today. And touching a little bit on some of the themes that Gail mentioned very briefly in her opening, you know, if we're successful today, a partnership is going to form among the various institutions of higher education as well as various community organizations as well. Because the knowledge that we're going to gain through the effort today and the knowledge that we gain through research, hopefully we'll be able to put into practice to where we can do some immediate good. But at the same time, I would hope then that the experience we gain in the practice will also help inform further research in sort of a continuous loop and partnership loop in that regard. So I'd like to personally thank each of you for your personal commitment to addressing this heroin and opioid challenge that we're confronting. It has a tremendous grip on our region. When you look at the impact on that region, it's not a surprise that we've got people here from 7 different states. But as you all know, this is not a regional or local problem. This is a national problem. If you look, according to the Drug Enforcement Administration's 2017 National Drug Threat Assessment, just released a couple of weeks ago, the number of heroin-involved overdose deaths quadrupled between 2010 and 2015. Heroin was involved in deaths of nearly 13,000 people in 2015, and that's the last year in which we have available data. But beyond those overdose deaths, the epidemic affects our communities in a number of different ways. And we're here today to talk specifically about neonatal abstinence syndrome. Now, in my lay understanding, what that means, we're talking about the impact of drug abuse on newborn children and as well as their moms. Now, I'm going to leave that kind of discussion to the experts because I'm not one of them. On the other hand, I'm a husband of a nurse who worked in the NICU at St. Elizabeth's Hospital for a number of years. And I'll tell you, she'd come home from work at times and was describing to me, you know, the heartbreak she felt at dealing with a mom, but the baby, the newborn baby in the NICU, born to an addicted mom. And she was describing for me on multiple occasions kind of the reaction that the newborn baby was going through. And I tell you, for me, I mean, just to hear it, not to see it, but just to hear it was heart-wrenching. And as I thought about it more, that was just the immediate short-term impact. I wasn't even thinking about the longer-term impact that might be yet to come. So I'll let you experts kind of work through that issue. That's as much as I know of the issue in that regard. But I do want to say a few things about the role of higher ed when it comes to addressing this and other health-related challenges that face our communities. For one, we're proud to host this conference. It's an important part of our university's broader commitment to a growing focus that we have at this university on population health. Then, next fall, we're going to open doors to our brand new $105 million Health Innovation Center. You may have seen still the construction site as you enter this building. That facility, including our Institute for Health Innovation, which will open sometimes and begin becoming operational in the early part of 2018, along with a partnership we have with St. Elizabeth Healthcare, as well as University of Kentucky, to bring a medical school to northern Kentucky. Those partnerships together, the Health Innovation Center, the Institute, will allow us to leverage an expertise that we already have here on our campus in terms of informatics to help prepare our students, our graduates, to design innovative practices to prevent and hopefully treat the chronic medical conditions of all types, this being one of them. In that regard, I just want to briefly say thanks to any of our St. Elizabeth folks that we have in the audience, because St. Elizabeth Healthcare has been a major partner for us with the Health Innovation Center, the facility itself, as well as helping to be an investor in the Institute and a major investor as well in the medical school coming to the area. So for all of you out there from St. E's, appreciate the support. In addition, back in 2015, we invited Sam Quinones to campus to talk about the heroin epidemic and what he had learned through his writing his powerful book, Dreamland, which I see copies at the table. His visit was a catalyst for our engagement on this topic. Classes read the book, research and reporting projects flowed from that, as did some very important community conversations, including conversations involving treatment gaps, public policy, and the value of intercollegiate collaboration and research as well that might help our communities address this very challenging problem. Later, we gathered about 40 people last December to see how we might go forward with what we had learned through that interaction. And the idea of a conference, this conference, emerged at that time. And our goal today is to learn more about this epidemic, including one of the most disturbing components, and that is the toll it takes on mothers and newborn children. More broadly, we're here to meet one another. We're here to explore how we might collaborate on research and evidence-based solutions to the challenge that confronts us today. Again, I want to thank all of you for coming here, and you come here from every walk of life within the community. And that's important because this issue really requires a multidisciplinary engagement. It's not one part of our expertise that can be brought to bear on this. It requires people from all walks of professional life, as well as just interested citizens who have lived through some element of this problem. All of those folks together have got to come together to work to solve this issue. So again, thank you for joining us today. And now it's my pleasure to introduce today's keynote speaker, and that's Dr. Judith Feinberg. Yes. Dr. Feinberg is a professor of behavioral medicine and psychiatry at the West Virginia University School of Medicine. And she's credited with establishing Ohio's third syringe exchange program, the Cincinnati Exchange Project. And she's currently developing a clinical research program on the opioid epidemic in West Virginia. Dr. Feinberg, it's my privilege to welcome you to NKU and to this conference and sort of back to the metro area. Dr. Feinberg, please.
Okay. Good morning, everybody. It's such a pleasure to be here. Let's see if I'm smart enough to figure this out. Oh, wait, I got somewhere. There we go. Okay. You know, I'm going to stand here because I didn't realize I couldn't see my slides. Okay. So I called this talk A View from the Belly of the Beast, and I think probably intuitively you already know that this is where we are. And I'm going to give you the data that supports this. And I call this the first annual ORVARC conference because I hope we'll have many more. Okay, here we go. So I'm going to talk about the fact that this is not just an opioid epidemic, that there's links between opioid misuse and addiction that lead to all these other problems. I think this is, oh, I didn't know if it, I don't know, you can hear me, right? I'm originally from New York, and most times I don't even need a microphone. I want to talk about the impact on families and children, and if I have time, I want to talk about prevention at the end. Okay. So I'm sure everybody here in the audience is in on this, but I start every talk with reminding people that addiction is a disease. It's a chronic, relapsing brain disease. It's not a moral failing. It's not a lack of character. It's not a lack of willpower. And, oh, there we go. Where's the rest of that? Huh. Well, there was a picture here that I don't know what happened to in translation, but it was a functional MRI of a normal brain and an addicted brain subjected to the same stimulus. And the picture shows that the brains look entirely different. So really, addiction is both a functional and a structural brain disease. I don't know what happened to the picture. Okay, so here's the start for me anyway. So I'm an infectious disease doctor by training. Oh, yeah, that would be much better, thank you. And this works, right? Yeah, okay. And actually spent the first 35 years of my career doing HIV research. And I was the attending physician at University Hospital in 2005, and in a 2-week period, I saw 4 people with endocarditis. Endocarditis is a bacterial infection of the lining of the heart, the covering of the heart valves, and you get it because there's bacteria in your blood, and injecting unsterile drugs through unclean skin is a great way to put bacteria in your blood. And at that point, I'd already been in Cincinnati for 10 years, and so I knew 4 cases in 2 weeks was unusual. And I'd come to Cincinnati from Johns Hopkins in Baltimore, which is a place that I call part of the 20th century opioid epidemic, as opposed to what we're dealing with now, like the 21st century one. And it made me stop and think. And then a couple of months later, I had another 2-week stint in the hospital. I saw the same thing again, and I knew that there was a heroin problem in Cincinnati. So I knew this in 2005. I got a wonderful ID fellow who worked with me, and we did a 10-year retrospective of all the endocarditis cases seen at University Hospital. And, there we go. And I put an asterisk next to 2005. That was the year I became aware, and turns out to be the year with the most cases. And what we discovered, and remember this is retrospective, so it relies on just what the doctors happened to do at the time. There was no method to it. And what we discovered was that overall, over that 10-year period, there was a 2-fold increase in endocarditis admissions. There was a 4-fold increase in those patients who also had hepatitis C antibody, meaning they had been infected by hepatitis C, and a 6-fold increase in people who had a toxicology screen positive for opioids. And this clearly represented a sharp increase in the number of people who were injecting drugs over this time period, and led me as an infectious disease doctor to want to do harm reduction, to want to prevent the spread of hepatitis B, hepatitis C, and HIV, which I know are readily transmitted by sharing injection equipment. And I started working then to start what the president so kindly said was the 3rd syringe exchange in Cincinnati, and it took 9 years, so it's not an easy task. It took 9 years to get the approval, and it took another 2 years to actually get the communities to agree that this was a reasonable thing to do. But along the way, health commissioners for the city and the county kept asking me, well, give us some data. How many people are there with an opioid problem? Well, you can't actually go out into the street and say, how many of you are shooting up? And see a bunch of raised hands. That's not going to work. So we did a bunch of focus groups. We did a survey among people who were injecting. And here's data from the work we did in 2009. We asked a lot of questions. I'm only going to show you 2 slides. One is that 2/3 of the people said they found used syringes somewhere. And most commonly, they found them in public places. And then we asked them, well, what'd you do with these syringes? And it turned out that almost 40% used them, and half of them without doing anything to clean them, and the other half cleaned them in ways that were absolutely inadequate. You can, of course, kill most viruses with a 10% bleach solution, and the scariest answer we got for this, how did you clean the syringe, was a young man who said, I use puddle water. So is it any wonder that people get endocarditis from injecting puddle water into their system? So the result of this is that you do find syringes in all these public places, right? So on the left is a child care center, just a couple of blocks from the UC campus. Here's another one in the planter outside the YWCA downtown, and I could point you to any number of places in Cincinnati, the names of streets where you can just go and see dozens of these things lying on the ground. And it's a real public health hazard, right? And especially for children, these needles glint in the sun, it's attractive. So it really presents a broad public health problem aside from the people who themselves are the injectors. So if you, in this era, in 2009, if I asked an audience like this, where are most of the overdose cases seen? Everybody would say, University Hospital. First of all, it's close to downtown, and downtown is a nidus of drug use. And second of all, University Hospital gets county money. It's, to defray the cost of taking care of indigent people. So it's a place where many people with severe problems go, and it's also the level 1 trauma center for the region. And you know what? That's wrong. This is where, in 2009, most of the overdose cases went to this lovely suburban hospital, Bethesda North, very close to Claremont County and Warren County. And this is the signal that the 21st century problem is different. This is a problem that started really in rural and then suburban areas. It's now, of course, in cities as well. But early on, these were all people coming from much further out than city center. And really, that's a significant difference from the 20th century heroin epidemic, which was very much an inner city, socioeconomically depressed and racial and ethnic minority population. Okay, so let's talk about the extent of the problem. There was my start. That's how an infectious diseases doc became an addictionologist. Okay, so opioid injection, whether it's prescription drugs or street drugs, actually is entwined with multiple other epidemics, and the public health term for this is syndemics. So we have acute hepatitis B, for which West Virginia has the highest rate, acute Hep C, which West Virginia just edged out Kentucky for the #1 spot. We have HIV as a possibility, and I'll show you the data for this in a little bit later, but more than 50% of the counties considered at risk by the Centers for Disease Control are in central Appalachia, and we actually currently have an outbreak in the southern coalfield counties of West Virginia, so that the CDC is actively investigating. We have sexually transmitted infections, especially syphilis has made a huge resurgence. We have, as I said, endocarditis and other serious bacterial infections that you get from bacteria circulating in your blood. We have overdose and overdose fatalities, for which, again, West Virginia's got the highest rate. Very much we have now in areas that are so hard hit, we're really starting to experience first responder sort of compassion and fatigue and burnout. You know, these are people who not a day goes by without the EMS or the fire department responding to at least one overdose call, and usually many overdose calls. It really is taking a toll on our first responders. I already talked about the risk of discarded syringes. We have vertical transmission, or that's just the medical way of saying mother-to-child transmission of hepatitis, HIV, and syphilis. You know, congenital syphilis for me, and I'm an ID doc, is something I only ever read in textbooks, right? I've been an ID doc for, I don't know, 35, 40 years. I've never seen a case, but they exist now. And then we have neonatal abstinence syndrome, and actually it really is in the process of being renamed neonatal opioid withdrawal syndrome, so from NAS to NOWS, for which West Virginia also has the highest rate. And the reason to rename it is somehow neonatal abstinence syndrome isn't really descriptive enough, and many people misunderstand that the babies are born addicted. They're not born addicted, they're born going through withdrawal from the exposure to the opioids in the mother's blood. And so this is probably going to be the appropriate new title and acronym. And then as a result of this terrible problem, we have children who are abandoned, neglected, abused. The foster care system is being flooded. In the southernmost county of West Virginia, 40% of the children in that county are in foster care. 40. Every time I say that, I get chills. It's a really horrible thing. In fact, the foster care system in West Virginia is so overwhelmed that now they're paying families in Virginia and adjacent counties to help take care of these children. There's nobody to do it. And then, of course, you know, as people lose jobs and exhaust all their resources, there's tremendous homelessness. So I want to start by talking about overdose mortality, because it's such a big deal here. So between 1999 and 2012, the proportion of deaths due to drug overdoses doubled, right? From 30% to 60% that opioids were responsible for. And nationally, around 2008, the line crossed with deaths from motor vehicle accidents. Actually, in Ohio, those lines crossed in 2007. So again, this sort of region is leading the way. Oh, none of my pictures came. Oh, how sad. Okay. I don't know. This is probably the incompatibility of Macs with whatever the system is here. Well, this was a picture of Appalachia and the death rate, was, this is going to be very sad that I don't have pictures. And the death rate is, the highest death rates are shaded in the darkest red, and I had a square around central Appalachia, which is really right southern Ohio, West Virginia, eastern Kentucky, northeastern Tennessee. And the mortality rate now in these areas is actually worse than the mortality rate in inner cities. And it's really driven by, this is a brilliant study done by Angus Deaton and his wife, and he's a Nobel Prize winning economist at Princeton, and he could demonstrate that this increase in rural and especially Appalachian death rates was driven by increased mortality among white men, middle-aged white men, 45 to 55, had never gone to college, lived in these rural areas, and in these cases, the primary causes of death were suicide, drug overdose, and liver disease. And when I show you how much hepatitis B and C we'll have, you'll understand the liver disease part. I'm going to be, at least one picture came through. Okay. So here is data from the CDC, and it goes from 2003 to 2014, and I put the little box around Central Appalachia in 2003, so you can see that we were part of this at the very beginning, and now as it's become a nationwide problem, you can see that there's such a concentration of overdose mortality in this area in the 2014 box. I hope good, other pictures, I'm so happy. So here is on the left, here is a heat map of the overdose deaths by county for West Virginia in 2014. And heat map right, the darker the color, the worse it is. And this county at the very bottom, I guess there it is. Whoop. So much for that, huh? I made them all go by. There it is. Well, at any rate, I'm not going to mess around with the pointer, but the county at the very bottom, that purple county, that's the county where 40% of the children are in foster care. And interposed there in the bottom right-hand corner is just a heat map for acute hepatitis C. Now, these are data from 2015, so it's 1 year apart. And I just used the lower third of West Virginia because you can see on the left that the lower third of West Virginia is the worst place. And this really indicates what the association is, right? Acute hepatitis C is almost primarily from drug injection, and there's the overdose death rate. So, there's no question about, what's really going on here. Okay, a lot of all right, so you just have to take my word for it that the overdose mortality rate in West Virginia is orders of magnitude higher than the overdose mortality rate in the rest of the United States. And in fact, in 2015, this was 41.5 people per 100,000. It really is an astonishing rate. And, this didn't even have a picture. I don't know what happened here. Anyway, the states with the highest overdose mortality rates in 2015 are West Virginia, 41.5. Number 2 is New Hampshire at 33, and tied for numbers 3 and 4 are Kentucky and Ohio at 29.9 people per 100,000. So you can see that, again, this area really dominates the problem. So let me move on to some of the infectious complications, hepatitis C and B. Okay. This, again, is a comparison between 2006 and 2012. And in the 2012, I put the same box around the same geographic area. And what you see here is an increase in acute hepatitis C from injection drug use in areas that were never really part of the HIV epidemic. Like West Virginia has really a minimal HIV epidemic. And here is work from the CDC by my buddy John Zabel, And he looked at data for Kentucky, Tennessee, Virginia, and West Virginia, and showed that over this period, 2006 to 2012, there was a tremendous increase in new hepatitis C infections, and the non-urban bars are the light blue bars, so you can see that they really outstrip the increase in urban areas, although an increase has been seen in urban areas as well. And it's not only more, but it's increasing at a faster rate. So here's also data from the CDC on hepatitis C rates by age group. And here you can see that the young adults, 20 to 29 and 30 to 39, you can see that those curves have just way taken off. And this is very sadly, not exclusively, but really primarily a disease now of adolescents and young adults, you know, people like 15 to 45. I mean, there are some older, and there actually are some younger. The youngest person seen in Boone County Drug Court was 9 years old. So it can be younger than 20, but there's where it's concentrated. And what's obviously particularly sad about this is, right, first of all, these are the years in people's lives where they're establishing their careers and their jobs, where they're having families. And this is the generation that, you know, this epidemic is taking out. So, you know, since 2006, more than 70% of this acute hepatitis C is clearly due to injection drug use, and probably most of it's due to injection drug use. The tie is not that clear. Okay. So this pic was supposed to be a picture of the 8 counties in Southwest Ohio that Hamilton County reports for on a monthly basis, reportable diseases. And in that month, August of this year, there were 284 new diagnoses of hepatitis C in these 8 counties. The majority of them were in Hamilton and Butler, which is just north of Hamilton, and Claremont, which is just east of Hamilton County. And the CDC has data that shows that the hep C rates in Ohio increased by 400% just in 2015. So an enormous burden of disease. Oh, I'm glad these came through. And I'm just going to show you very quickly a succession of heat maps for West Virginia for diagnoses of hepatitis C. So this is 2012, 2013, 2014, 2015. You know, and if that isn't enough to sort of put a chill in your heart, I don't know what is. And again, this diagram doesn't come through, but it parallels the one for overdose mortality. You can see that the US rate of hepatitis C increases a little bit, and the rate for West Virginia skyrockets. And in 2015, Kentucky had the highest rate, but I believe in 2016, it's now West Virginia has the highest rate. And same thing for hepatitis B. I have no idea why these slides are not working. So I want to segue into HIV risk, because where there's injection and where there's blood being shared and exposed, there will be HIV. It's easier to get HIV from someone else's blood than from sex. And it's a very efficient way to actually transmit HIV. So I'm sure you've all heard about Scott County, Indiana, kind of between Cincinnati, and I didn't put the other star there, probably closer to Louisville. And this is a very urban county in Indiana. And at the end of 2014, they started seeing like 3 or 4 cases of HIV in a county that had never had more than 1 or 2 cases a year. And the CDC came in to investigate this. And now, you know, through the end of 2016, they've a cluster of cases that are 220 people with HIV, the vast majority of which also have hepatitis C. And primarily this is centered around a town called Austin, which has about 3,400 people. So 220 people out of 3,400 is a significant proportion. So here's the story about Scott County. Of the 92 counties in Indiana, it's 92nd for health status. It has very limited access to health care, few physicians, high unemployment rate, a really high poverty rate, and almost a fifth of the people in that county have not graduated from high school. So the CDC looked at these data and looked at the acute hepatitis C data and put this together. And hepatitis C turns out to be a great marker of injection drug use because by the end of 1 year of injecting, more than 70% or so of people will already have hepatitis C. And they came up with this map and a list of 220 counties that were at high risk of an HIV outbreak similar to the outbreak in Scott County. And once again, there's my box, and more than 50% of them are here in central Appalachia. And as I just told you, we're investigating a problem in West Virginia. I think when people in the media ask me, do you think there'll be another Scott County? My answer typically is, I think that's already happened, and we don't know it, because testing rates are so low. Yeah, Mike Kalfas is saying, yeah. Testing rates are really low. They're low in cities. They're really low in rural areas. I mean, and you know, once you get HIV, on average, it takes 8 to 10 years to get sick. So lots of people can have HIV and spread HIV before it ever develops into AIDS. And in the next slide, oh, it's so random which ones show and which ones don't. This is a map of West Virginia with the counties that are affected, were colored green, and it's 51% of West Virginia's 55 counties. So it's more than half of our counties, and it accounts for 13% of the US total of those 220. And West Virginia is the second highest number, and here was the picture for Kentucky that doesn't show up. Kentucky is number 1. It has 54 listed counties out of, I think, 124. I don't know, Kentucky's got more counties than anybody. And here is now this one shows, isn't that weird? And this is the one for Ohio. Ohio only has 11 counties at high risk. They are all obviously clustered in the south and southeast portion of the state. And the fact that in these areas, these counties are geographically so clustered really makes you think that if we had a concerted effort across state lines and across institutions, we could probably do something about this. It's not like one's way up in Toledo and one's way up in Cleveland and there's another one in Columbus. They're all in one area. So I want to move on now to talk about the impact on neonates and start with an introduction about how readily HIV, Hep B, and Hep C are transmitted. And if you look in the bottom, the mother-to-child column, then you see that hepatitis B is really incredibly easily transmitted from mother to infant. Hepatitis C, less so. We don't really have accurate data about hepatitis C. I'll come back to that. And HIV is like in the middle. So why do we care about this? Well, first of all, women of childbearing age acquire these infections. And they acquire them from unprotected sex, and they acquire them from injection drug use. And although vertical transmission of these diseases, you know, the impact on the baby can be very different, nonetheless, the consequences are really serious. And it's important now because probably half of the people with opioid use disorder and who are injecting opioids are women in this part of the world, in central Appalachia. And that is, again, sort of a real big difference from the 20th century heroin epidemic, which was really overwhelmingly male. And I think that our 21st century epidemic in the early 2000s kind of started in men, but incredibly rapidly spread to women. So mother-to-child transmission of HIV is pretty variable. It depends on what country you live in. So in the United States, it's about, if you don't intervene in any way, it's about 25%, 1 in 4. You know, in Africa, it can be 2 out of 3. But if we give the mom appropriate medication during pregnancy, then it's rare for an infant to be born with HIV. And we do this by, it's part of a routine part of prenatal care, of screening all pregnant women for HIV. And if they come into labor and delivery and they haven't been screened, then they get an immediate rapid test for HIV so that the mom can get intravenous AZT, the first drug we ever had, and that we can give drugs to the baby right away afterwards. And you know, this reminds me that in September of 2006, the CDC came out with recommendations saying everybody who's ever been sexually active between the ages of 13 and 65 should be tested for HIV at least once in their life. And I don't think this is happening anywhere. Rural or urban or suburban, I think it's just not happening. And I don't actually know why the CDC used 65 as a cutoff. People older than 65 have sex too. So it's like, I don't know where that came from, but you know, it's like hard enough, right? They always say it's hard enough to picture your parents, but then picturing your grandparents, that's probably behind it. And here is, again, CDC data about the incidence of perinatal AIDS going from 1985 to 2010. And that huge peak is the early 90s, when more and more women were being infected with HIV, and then having infected babies, and the sharp decline comes when we did this famous study, ACTG 076, where we proved that if you give the moms AZT during the last couple of trimesters of pregnancy, it drops the transmission rate hugely. And now that we know that the standard for treatment for HIV is 3 drugs, not 1, we give the moms, the same pregnant women, the same triple drug cocktail that all other adults get, and it is now absolutely rare for a baby to be born with HIV in the United States. So, and this was actually the first home run in the AIDS epidemic. This was the first piece of really good news, and it was a very exciting thing. Mother-to-child transmission of hepatitis C, you know, clearly this is the leading cause of how children show up with hepatitis C. Part of the problem here is that, you know, the majority of pregnant women really don't initially even realize that they have risk factors for hepatitis C, or, you know, if they, you know, they're injecting, maybe they don't know that they could get a hepatitis C, so that doesn't really get transmitted to the obstetrician or to the pediatrician taking care of the baby. But the sad thing is the vast majority of hepatitis C infected infants have not been identified, and that's because the women don't know, and therefore their doctors don't know. And here's the kind of the most recent published data over a series of studies that showed that the median risk, if you only have hepatitis C, of giving it to your baby is about 6%. If you have hepatitis C and HIV, it's about 11%. But the range, as you can see in the column above, is quite a bit higher, right? It can be as high as 11% or, you know, 29% respectively. So this is a, you know, and we are currently about to do a study to really understand the natural history of hepatitis C in pregnant women, because there have never been this many pregnant women with hepatitis C giving birth, ever. And these studies are based on very small numbers of women. So I'm not sure that these really adequately represent the reality. Oh, how sad. Okay, so here's data that the CDC did based on, they got all of the lab data from Quest Laboratories and did an analysis here in Kentucky and showed that hepatitis C, positive hepatitis C blood tests, both in women of childbearing age, which is generally considered to be 15 to 44, and children under 2 in Kentucky were like going up like that, And then the United States was pretty level with a slight increase in the recent years. And then another piece of this analysis was that then they specifically looked at infants, the number of infants who were born to women who were known to have hepatitis C here in Kentucky, and again compared it to the United States, and it's the same dramatic thing. A big increase in the number of these infants being born in this situation compared to a pretty level situation across the US. So lastly, I want to talk about mother-to-child transmission of hepatitis B. So this is a big problem. As I showed you before, it's very easy for a mom to give a baby hepatitis B. The vast majority of infants who are born to hepatitis, moms with chronic active hepatitis, will themselves become chronically infected with hepatitis B if there's no intervention. So it's sort of almost a given that that will happen to these babies, and that's why screening for hepatitis B is, of course, a part of all recommendations for prenatal care. Even if they say they've been vaccinated, you're supposed to do this. And then when these moms give birth, you immediately give the babies the vaccination for hepatitis B and then hepatitis B immune globulin in an attempt to block the transmission of B from mom to baby. And as I said, the vast majority will become infected if you don't have that intervention. So, you know, that's problematic if women have not had any prenatal care and just come into labor and delivery, and they don't know they have hepatitis B, and so the medical personnel can't do anything for the baby. And these babies tend to be asymptomatic, but they become chronic carriers. They become chronically infected because they've met hepatitis B before their immune systems are very robust. And they have a 40% lifetime risk of developing cirrhosis, end-stage liver disease, and liver cancer, which is part of one of the things that happens with cirrhosis. So a very serious outcome. Now, what happened here? So neonatal abstinence syndrome, or probably the better new title and acronym now, is neonatal opioid withdrawal syndrome. This is a map of the United States from a CDC analysis. We've already talked about how this is really the postnatal withdrawal syndrome. And in this analysis, the CDC looked at 28 states between 1999 and 2013. And overall, there was an increase of 300% in these babies being born, from a rate that increased from 1.5 to 6 per 1,000 hospital births. And in 2013, of course, sadly, West Virginia was #1 for this, 33.4 cases per 100,000 hospital births, and highest rate in the country, followed by New Hampshire and Maine. And in 2016, 5% of all the babies born in West Virginia had been exposed to drugs in utero. And in some communities like Huntington, that proportion is way higher. Oh, so depressing. Okay, well, this was a map of Kentucky, and superimposed over the map of Kentucky was the graph of neonatal opioid withdrawal syndrome over this 11-year period, and it started being very low in 2000, and by 2011, there were 730 babies born in Kentucky with opioid withdrawal. I never understand what happened to these slides. So one of my huge concerns is, what's the future for these children? And in saying that, what's the future for us? What's the future for our communities? These babies that have been born with opioid withdrawal have been described as having delayed developmental milestones, behavioral problems, and intellectual deficiencies. And you know, we're starting to hear anecdotally, for example, from kindergarten and first and second grade teachers in West Virginia, how difficult it is to teach these children because of both behavioral and intellectual issues. We have enormous problems with family disruption, right? We have parents who are incapacitated either because of their opioid use disorder, because they're in jail or because they've died from an overdose. And it's very much like the AIDS and crack epidemics from the 80s and 90s, where now you have this huge proportion of grandparents who are raising children again. And as I mentioned before, the foster care system is really overwhelmed. And since, for example, in eastern Kentucky and West Virginia and southern Ohio, these are among the poorest counties in those respective states, then you try to imagine what is foster care like in the poorest county in Kentucky or Ohio or West Virginia. It's probably not fantastic. And overall, what we're really seeing is communities in crisis. These are areas that have had tremendous loss of industries, manufacturing jobs, mining jobs, so that, the economic core of these places has been hollowed out. And, the resulting thing is there's just a complete disruption of the social fabric. So, for example, in communities in southern West Virginia, where due to the population decrease, they're trying to combine school districts across county lines. So kids are going to not travel a big distance every day to go to school. But social research has shown that when local schools are taken out of a community, it's like taking out the community's heart. That, it's a gathering place. It's the Saturday night football games. It's parent, the PTA. It's a focus of a community. And when a small community loses its schools, this is research done by my colleague, Dr. Rita Callistra in West Virginia. When they lose their schools, they just really go into a dramatic decline. So this whole opioid thing has implications so far beyond just the medical pieces, but it's an enormous, economic and social tragedy. And of course, with all of these problems with the babies, it's a two-generation crisis, right? We have all of these addicted people who are in the parental age group, and now they're having children who are either in foster care or who damaged by their opioid exposures in utero. And it's like the loss of another generation. I find this unbelievably tragic. Do I have time to talk about prevention? I have a couple of minutes. Let me zap through this. So harm reduction, okay? This is a very important public health strategy. And the point is to minimize the harmful consequences of something is bad and that you don't condone. Like, nobody wants to say injecting opioids is a good thing. But if you can reach people and develop a bond of trust, eventually people, they come to the point where they're ready for treatment and they're ready to do a better job taking care of their health. And it's really about sort of meeting people where they are instead of insisting that they be where we want them to be. Come here and enter drug treatment tomorrow. It's about starting from their perspective. And, syringe services programs, for example, the access to sterile syringes and sterile injection equipment, which is really important to prevent the spread of hepatitis C, keeps people alive and healthy until they're ready for drug treatment. That's the whole purpose, alive and healthy, till you can move to the next stage. And it's been shown that syringe services program reduce the risks of hepatitis C, HIV, overdose, and overdose fatality. And they don't increase crime, and they don't induce other people to start injecting who have never injected before. There's a lot of shibboleths about this, but none of it's rooted in data. So here is a picture of the pink are the 220 counties at high risk. The green dots are where there are a syringe service program, and I hope this next slide comes through. There we go. And here's our part of the world, and you can see we absolutely do not have adequate harm reduction in this part of the world. So while people's heads are buried in the sand, hepatitis B, hepatitis C, and HIV are going to spread dramatically, right? I mean, it's really dramatic. So here's my last slide about preventing infection and preventing death. We need syringe services programs, clearly, and because they not only give out syringes, but the previous phrase used to be syringe exchange program, and that was just dirty needles for sterile needles, contaminated needles, I should say. But a syringe services program is so much more than that. It's not just the syringes, it's the other implements that people use to prepare the drug for injection so that they don't get hepatitis C. It's on-site rapid testing for HIV and Hep C. It's condoms and safer sex information. And in the Cincinnati Exchange Project, it's very focused on linking people to drug treatment when they're ready and to medical care and to mental health care. Hepatitis B vaccination rates are inadequate in many places and states that allow parents to opt out too readily of vaccination are putting a generation of children at risk. In areas where HIV has surfaced or where there's concern of it surfacing, you can do this pre-exposure prophylaxis, give people a pill a day and they don't get HIV. We can screen and treat people for their sexually transmitted infections. We can screen and treat people for HIV and Hep C. We can actually cure hepatitis C now in 8 to 12 weeks, which is quite amazing. And then in terms of prenatal care, of course, it's already part of the standard, as I mentioned, to screen for HIV and hepatitis B. But my recommendation is, and that's why it's in bold and the asterisk at the bottom doesn't show up, I think that any woman who's pregnant in Central Appalachia should be screened for opioid use and for hepatitis C, because we're never going to know who we have to pay attention to if we don't have that data. And then lastly, of course, to save lives, access to naloxone. Ready access to naloxone is very critical. So let me stop there, and thank you very much for your attention.
Thank you so much. That was wonderful. Absolutely. Okay. Thank you so much, Dr. Feinberg. That was such a great way to start with all the data and giving us a great framework and overview of the work. And we're very appreciative that that infectious disease doctor is working on this, this work. Next, I'd like to welcome to the stage Dr. Henrietta Bada. Dr. Bada is from the University of Kentucky Medical School, which will be opening a satellite medical school at NKU probably in 2019. Dr. Bada is a neonatologist, and among her clinical and research interests is neonatal abstinence syndrome. She will give us a sense of what the current research tells us about NAS, aka NOWS. You pronounce it NOWS? Is that what you say, NOWS? And what we still don't know. Dr. Bada? Would you like to use the handheld mic or this one? Handheld, okay. Mm-hmm. Do you? Okay.
Thank you. And first of all, I'd like to thank the consortium for this invitation. The topic assigned to me is a little bit broad. I hope I can give you some good information, and I can assure you that I will also probably be ending up giving you some confusion. There's a lot of we see a lot of babies with neonatal abstinence syndrome or opioid withdrawal, but the main thing is we're doing things as clinician. We try to see what's our best approach, and one approach may not work with one person, but it may work for another. So we end up with, for the most part, differences in the way we approach babies with neonatal abstinence syndrome. I'm also currently assume the role of the division director for maternal and child health for the state of Kentucky. So it's a difficult position because as a physician, you want to treat your patients, but then as a public health person, you have to look at things at the population level. So I get a little schizophrenic. What I'm going to do is go over briefly the epidemiologic significance of neonatal abstinence syndrome, some definitions, and then the effect of prenatal drug exposure on brain development, establish prenatal exposure, how do we do that, and then how do we assess newborns with neonatal abstinence syndrome, and what are the treatment and the outcomes of these babies with opioid withdrawal, and then what are the influence of risk and protective factors on the development of these children, and some future direction. I hate to say this, but in my opinion, neonatal abstinence syndrome is not going to disappear. In 1960s, we saw the heroin epidemic, and that's when we started the use of methadone to treat babies exposed in utero to heroin. And then in the 70s, there's continued use of heroin, and it was dropping down some. And then a lot of these babies are born to mothers on the methadone program. And then by 1980s, we have the methadone and also hydromorphone, dilaudid. And the main thing is, in that epidemic for drug use was cocaine. And a lot of studies, especially longitudinal studies, have been carried out because of cocaine exposure. As a result of the press releases here and there saying that these babies are monsters and born to mothers unfit to parent, and basically the media gave a poor, gloomy picture about babies exposed to cocaine in utero. And we know now that the effects of cocaine actually on child development are actually effects we call subtle. There are some impairments, some behavioral problems, but these children were not born as monsters. And then in the late 1990s and also 2000, there's still continuing cocaine use. It is continuing to increase. But then we started seeing increase in use of opioids, primarily OxyContin, and then you all know about OxyContin Express, the use of oxycodone, and also tramadol. And with that, we started seeing babies having withdrawal. In fact, there was a report from University of Kentucky from one of our associates, and they reported this baby having symptoms just like heroin withdrawal. And they did drug testing. They didn't find anything. They said, there's got to be, we have to be missing something. And that's because they were not able to get them test the metabolite of oxycodone. And then when they did further testing, then it was established that baby had withdrawal manifestation from OxyContin. And then and then as we go to the 2000s and to the present time, we have methadone, which is actually street methadone use is actually decreasing, replaced by Subutex or Suboxone, your buprenorphine, and also some other opioids like tramadol is also Demerol. We're seeing that, and of course fentanyl. So now we're back to the recent years, and here we are with an opioid epidemic. And so we are still seeing, and we are actually seeing an increase in babies with neonatal abstinence syndrome. So here's the data from Kentucky, and this is from hospital diagnosis of neonatal abstinence syndrome. In 2001, we had 46 babies with that diagnosis. In 2013, 756, and 2014, 1,060. And when we did this, as I said, is from medical records, from hospital discharges, and in 2015, we have the NAS surveillance registry. So it was mandated that hospitals report the diagnosis of neonatal abstinence syndrome. And the number in 2015, 1,354 babies. And this is residents of Kentucky. If we add West Virginia to that, then we'll probably be higher than we have seen in Kentucky. And so the report of 1,354 babies is based on a total report of 173. But there are some babies transferred from a level 1 hospital to a level 2 to the regional referral center. So we have to make sure that there are no duplicates. So that's how we ended up with 1,354 unduplicated cases. 90% of those reported had positive maternal history for substance use, opioid use. 77% had positive maternal drug tests, and 76% infant drug tests. Most common, buprenorphine, opiates like OxyContin, Lortab 20.3%, and also marijuana in 12%. The infant tested positive, a third of them tested positive for buprenorphine. Other opiates, 27%, and this other thing, benzodiazepine, we're seeing an increased exposure to benzodiazepine, usually in conjunction with the opiates. And here's our map by district, and the rate for Kentucky in 2015 is 24.3 per 1,000 live births. And if we look at what's going on in northern Kentucky, it's around greater than 30 per 1,000 live births. And we have this area in here in eastern Kentucky, which is 3 times as high as our state average, as high as 63 per 1,000 live births of babies with neonatal abstinence syndrome. When we look at the characteristics of babies with neonatal abstinence syndrome from our registry, most of them are white. And then education of the mothers, this is linked to birth certificate, 30% less than high school education, 37% from rural counties, 70% of course not married, and then mostly Medicaid, no prenatal care in 19%, or late prenatal care. Tobacco use, 80%. So not only are we dealing with the effects of opioid exposure, but also nicotine or tobacco exposure. And hepatitis C, 25.6% of the mothers were positive for hepatitis C versus 1.4% in babies not exposed to, with no diagnosis of neonatal abstinence syndrome. Low birth weight, 18.3% versus 8.4%. We also have data from our quality initiative from about 2,000 cases, and we asked for maternal treatment during pregnancy. Did the mother access treatment? And they have 39%. So you have about 60% of these mothers who are not in treatment. Now, we were kind of, skeptical about treatment when we interviewed them about treatment. So we asked them, well, if you are on treatment, did you continue treatment at discharge? Only 57% of these mothers continued treatment at discharge. And did your program include drug testing? Only 25% had drug testing. Did you get mental health counseling? Only 22% had mental health counseling. How about parenting classes? Only 5% provided parenting classes. So we have to visit or evaluate what kind of treatment programs these mothers are getting. I think in general, it seems like treatment program represents MAT, so if they're getting buprenorphine or methadone, that's treatment program. And we know that there's a lot more than just getting these medications to be able to be treated for addiction or drug dependence. So when it comes to the neonatal opioid withdrawal symptoms, let's look at the effects. And from animal studies or experimental studies, we know that it's been shown that when you give prenatal morphine, especially to rat moms, the pups have decreased neurogenesis or synaptogenesis. So this would explain the decreased brain size, small birth head circumference in these babies. Small brains also found on autopsy, decrease in brain volumes in older children with prenatal opiate exposure. And then there's also an effect on the stress axis. That means it's the way how they respond to stress, which is maybe a reason why these, when they grow up, they have all these behavior issues because of their inability to respond to stress. There's also an effect on the immunologic response, and that would increase the risk for when there's transmission of diseases like HIV and hepatitis C and B. Also, neuronal death neuronal cells death is also reported, or we call it increase in the apoptosis of brain cells. And the unfortunate thing is, if we look at the developing brain, if we have imaging, we can see this. We can see gross malformations, but we don't see that in opiate exposure. But if we are only doing imaging, we're not seeing different stages of brain development. And so if we just have a small brain, a baby with a small head, everything else is okay, we will have that impression that everything will just be fine. But if you do imaging in these kids and you do quantitative brain volume determination, and here's a brain from a term, actually a preterm infant that has gone to term, and you can see the red showing the gyri and also the neurons or the gray matter. But here's a baby born to a mother who was using Lortab during pregnancy, a term, and you can see the decrease in gyration and smaller gray matter volume in this infant. So with that in mind, that there may be some effect or their effect on brain development, we want to know, how do we identify these babies with prenatal exposure? And I agree with Dr. Feinberg, there should be universal screening for opioid use in pregnant women. And sometimes, depending on our hospital practice, our suspicion is based on the multi-gravida, that means she has 3 or more children when she didn't have prenatal care. Then we ask, where are your other children? You have been pregnant 4 times. Where are the other children? Well, they're not living with mom. So there's likely a Child Protective Services involvement. There's a history of placenta previa or abruptio. And then the history of injuries, physical injuries, because this is a hallmark of domestic violence. History of pain, headaches, migraine, and of course the sexually transmitted diseases and risky lifestyle. And when you're seeing these moms, we look at how she expresses herself. Is she disoriented? How is she doing when you're interviewing her? But then we really go for biological screening, in addition to the mother admitting to drug use, urine, hair analysis, and in the newborn, we do urine screen, meconium drug screen, hair analysis, and umbilical cord analysis. I really like the meconium drug screen, but even with that, there is an issue, because if you can probably detect positive results around 20 weeks of gestation or later. If she has taken drugs before that, you might not see it in meconium at all. So there are some issues with some of the screening. Umbilical cord analysis is quite good in looking at benzodiazepine exposure and cocaine, but I think they have some false negative results when it comes to opiate detection. So these babies will have manifestations within the 72 hours of birth, and time from birth to 2 weeks, and some may present with withdrawal 2 to 4 weeks later. The issue is, what we are not clear about, is there's the onset of manifestations and maybe even the severity will depend upon the drug use during pregnancy, single drug versus polydrug use, and most of these mothers are polydrug users. So it's difficult to tease out outcomes of these babies related to just opiate alone, to just smoking alone, to marijuana, or a combination. Also the dosage, this is also another confusion, because both mothers on methadone, higher dose of methadone during pregnancy will not necessarily mean a severe withdrawal manifestation or you have a low dose of methadone, and the baby will have severe withdrawal manifestations and require treatment. And also the issue of anesthesia, analgesia, labor and delivery, it can delay manifestations of neonatal withdrawal. And then fetal accumulation, and it's maybe delayed excretion due to tissue binding. So there's a lot of things that we don't know that what's happening to this baby when exposed to opiate in utero. And that's why we're so confused on why one baby is so different from the other when they're manifesting neonatal withdrawal. And of course, the signs and symptoms, central nervous system signs, hyperactivity, irritability. I wonder if this will. You can see how this baby's, the hands, the tremors, which are severe, and the very shrill cry. And there are also gastrointestinal signs, like this is really very important because they don't feed well, they have excessive sucking, but then you give them the nipple and they won't feed the bottle. They have vomiting, and they lose the watery stools, which would make them lose weight. And of course, you know, if you're having loose stools, diarrhea, you don't feel well either. So these babies won't do very well. And then they have sweating, fever, yawning, mottling, and respiratory disturbances, nasal stuffiness. They breathe fast, they have retractions, and in this baby is born to a heroin dependent mother. And let's hear the, oops. Can we get the video on that one? Cute baby. So you are seeing here the excessive sneezing. You know, sneezing is normal. When a baby has more than 2 or 3 or 5 in a row, that could make you suspicious of a withdrawal manifestation from opioid exposure. And of course, there are tremors, and they're irritable, and so they have excoriations, fever. And so the duration of withdrawal may last 6 to 7 days if they're not requiring treatment. If we're really good at non-pharmacological treatment of these babies or behavior intervention. But in some babies, it may be longer, as long as 3 to 6 months. And then the evaluation of the withdrawal using the Finnegan Neonatal Abstinence Scoring System. There's some modification. We have used Brazelton, which is a little bit more, it's time-consuming, and it really needs some training. And same thing with the NICU Network Behavioral Scale. And recently, there's a use of the modified Finnegan Scoring System. And the issue with the Finnegan Scoring System is it's lengthy. So investigators want to modify it to make it shorten, to simplify it. And others are not even scoring at all. So as a researcher, how can you share your experience when you don't have an objective way or evaluating these babies with neonatal abstinence syndrome? And so it does not allow for comparison among practices and outcomes. So for the management, the mainstay is behavioral intervention, non-pharmacological measures. So the challenge for everyone is that you hope that you can avoid treatment of these babies with morphine or with other drugs for their withdrawal manifestation. I think that should be the goal. Give this baby the TLC that he or she would need so we can avoid giving these babies more drugs. And of course, we watch weight gain. They may need high caloric formula and IV fluids. And if all else fails, then pharmacological treatment. Another issue that's giving us confusion is when do you treat based on the scores? There's variation in reported threshold for treatment. Some use 8, some use 7, some would use 12. some would use 10. So there's really no uniformity in that regard. In the University of Kentucky, we use 3 consecutive scores of 8 or greater, or 2 consecutive scores greater than 12. And the reason why we need the consecutive scores, talking to Loretta Finnegan and watching these babies, their behavior can differ from 1 hour to the other. So if I give if the baby has a score of 10, and I said, oh, I go ahead and treat, but you know, how do you know that the baby really needs treatment? Because if you observe these babies closely, you will have a score of 10, the next 2 hours or 4 hours, it'll be 7, and then 3 hours of that would be 6. So you really don't need treatment because there's variability in how these babies manifest. The first-line drug is morphine, given every 3 hours, but then for research, there's still studies needed to compare weight-based versus symptom-based dosing. A simple pharmacokinetics would help us, but nobody has done that study. Should you give a dose of morphine based on what the severity of the baby's symptoms, or should you base it on the baby is symptomatic, but you calculate your dose based on the weight? So just this thing has not been done, but people are doing their own thing, so another confusion. Now, is morphine really the best drug? That's a question, especially when we know that prenatal morphine can cause decreased neurogenesis and all these symptoms that I mentioned earlier. So with the reported effects of opiate in the developing brain, why do we continue with opiate for treatment of neonatal abstinence syndrome? I don't think there's really an answer to that. We just did it. So we designed a pilot study in order to look at clonidine as an alternative treatment for neonatal abstinence syndrome. And clonidine is an alpha-2 adrenergic agonist, and it can actually minimize withdrawal manifestation. It has been used in small series as a single drug with improvement of symptoms, and there are larger studies using it as an adjunct to morphine or chloral hydrate. So we decided to determine whether clonidine can be as effective as morphine in the treatment of NAS, looking at treatment duration, hospital stay. In particular, we were interested in neurobehavioral performance. So this is a randomized trial, mask. Nobody knew what the baby was getting, which was really difficult. But only the pharmacist knew what the baby was getting. So we have to order study drug at this dose, and then if you need to increase the dose, then we say increase by 10% or increase by 25%, so we had a protocol for that. And there's no difference between the morphine and the clonidine as to birth weight, Apgar scores, and age when treatment was started, and no difference as to the Finnegan scores before treatment, 4 to 8 hours after treatment, 7 days after treatment was started, and 14 days after the start of treatment. So we can say, well, it's a comparable effect on treatment of neonatal withdrawal. And then when it came to duration of treatment, it was shorter with the clonidine versus the morphine. When we look at neurobehavior, I think the nice thing is that there is improvement in the neurobehavior of the infants who were on clonidine with better attention, and then also improvement in their arousal, and also in their handling, and improvement in their excitability compared to morphine. And when we look at outcome at 12 months, here we found that they're also comparable to term babies. There's no difference between morphine and clonidine. So we're currently starting an NIH-funded study to determine, have more babies and determine and compare clonidine and morphine. Because of research in our group, one of my associates actually looked at cell death, neuronal deaths in rat pups when the moms were given saline versus oxycodone, and then the pups were treated with clonidine versus morphine. And looking at here, you can see the largest number of cell deaths occurred in the oxycodone-treated moms, and the baby was treated with and the pups were treated with morphine, whereas there are less neuronal or dead neuron cells when the pups were treated with clonidine. So there sits at least some support in the use of a non-opiate for treatment of neonatal abstinence syndrome. So we need to minimize symptomatology, promote weight gain, and an important factor, promote caretaker-child interaction. We're not just treating the child, we're also treating the mother. And we have to have the strategies directed to social issues in order to improve short-term and long-term outcomes. We have, the previous speaker mentioned about child abuse, neglect related to drug use, and then the long-term behavioral problems of these children. So the issue here now at discharge, are the babies being discharged to the mother? Is it at home or in a residential treatment? Or kinship care, non-kinship care, and group home? I'm skeptical about group home because the first few months or first year of life is very important for for attachment. And if the baby is separated from mom or from a caretaker for a long time, I really don't know how it's going to affect long-term outcome. So the challenge, we know there's increase in hospital cost with neonatal abstinence syndrome. There's also an increase because of increase in hospital stay. But is that really the best marker for quality of care we're delivering to these children and to these mothers? What happened to these babies post-discharge? Well, what do we know? How many of them go for well-child visits? How many are up to date with their immunizations? How many are growing appropriately? How many ER visits after discharge? How many hospitalizations? How about the changes in placement? And then how about the mother? Did she continue with their treatment? Or we lost her completely? So the baby has to be in a permanent placement. And then how about follow-up for checking this infant for hepatitis C? And this is the number of babies we saw in University of Kentucky with a marked increase from 2005 to 2014, babies born to mothers positive for hepatitis C. The other issue I want to address is infant mortality. And this either due to sudden unexpected infant death, because NAS is a risk because of unsafe sleep practices and impaired caregiver from substance use, and death from abusive head trauma, physical abuse, or neglect. So in our external child fatality, near fatalities panel, in the review of deaths and near fatalities and near fatalities, categories of maltreatment, physical abuse, neglect, and impaired caregiver. Now, when we look at the risk factors in these fatalities and near fatalities, 67% substance use in the home, domestic violence in the home, and mental illness. Aren't all these three factors present in most families when there's substance use? And then when you look at infant mortality, Kentucky does not have anything to be proud of here. Our rates over the years is higher than US. In 2016, 6.7 per 1,000 live births. And when we look at the causes of death, prematurity is number one, 26%, prematurity-related condition. Look at sudden unexpected death, 22%, birth defects, 22%. Over the years, the most common cause of infant mortality is really congenital malformations. These kids are not dying anymore from congenital malformations. A lot of them are dying from sudden unexpected infant death. And this would include SIDS, death from unknown causes, accidental suffocation and strangulation in bed. And if we look at SUID rates, this is for the US, the big drop in the 90s, and combined SUID rate with the sudden infant death. And look at this, in 2015, the rate for the US, 92.6 per 100,000 births, okay? And here's what we have in Kentucky in 2016, 103 SUID deaths in Kentucky. We only have 50,000 live births. So you're talking about 200 200 SUID deaths per 100,000 live births in Kentucky, double that of the US. And we ranked #1 in the opioid when it comes to NAS, or close to #1. So we look at the SUID cases, and if you look at here, the hatch bars, 95.3%, 93.7%, this is showing you that the death is related to at least one unsafe sleep factor, okay? And the more common ones would be the surface that's not designed for sleep, and also other hazards in bed, all the toys, everything, blankets around this baby. So what does it mean? For every 1,000 babies in Kentucky, born in Kentucky in 2015, 6.8 died before their first birthday. And that's 379 babies. And what does it mean? The equivalent of almost 20 kindergarten classrooms of children that will never be filled, because these babies died too early, before their first birthday. So another thing for research, when we look at long-term outcomes, perinatal factors, or factors that may affect long-term outcome. How does the duration of in utero exposure affect outcome? We don't know. How about dose effect relationship? We don't really know. How about the polydrug use? When the mother is on MAT alone, would that be better than when you have a mother on MAT and still using benzo, or she has other mental issues? How about the severity of withdrawal manifestations? We don't know. What's the relationship of severity to long-term outcome? How about the continuing exposure from postnatal treatment? We don't know. How about the type of drug that we use for treatment? We don't know. We don't know how they relate to outcome. And of course, adding chaos to or confusion is the family and environmental factors. This is a case control study from Dr. Hunt, which was quoted in the Journal of American Medical Association. Cases of children born to mothers compliant with their methadone program, controls negative for drug history and drug screen, and the follow-up at 18 and 36 months, and basically it showed there's not much difference between controls and the opiate exposed as to motor development, but they have lower MDI, or mental developmental index, IQ, and lower language scores, expressive and receptive. So we are seeing some delay, not just delay, but actually some impairment in cognitive and language development of these children. And we also look at, in our clinic, we have data from 127 children treated for NAS, 1 year and 2 year outcome. And those, again, we didn't find difference in the motor outcomes, but when it comes to cognitive outcome, 85, which is your 1 standard deviation below the mean, and also a decrease in language scores, and these are statistically significant. So if your median is 85 or 84, which is 1 standard deviation below the mean, it means then that 50% of your children have scores at 1 standard deviation below the mean, way, way down. And are we happy with that the children is having those lower scores going to school? So we have to look into the effect of protective and risk factors. So can we change outcomes? And basically, this is from our study, from the maternal lifestyle study. We look at risk and protective factors. And one thing I want to highlight here is caretaker involvement. And you have to really start that early on, not when they're adopted or not when they're already in school or 5 years of age. And so we looked at the balance between the high risk index and low protective index, high risk and high protective index, low risk, low protective, low risk, and high protective index, because we're looking at the balance. And then we look at the problems, and for here we'll do the total behavior problems. And the interesting thing is, and this is the group of children out of 1,000 that we followed who did not have cocaine exposure, but had opiate or tobacco or marijuana exposure, okay? So the top line shows you what happens to this kid's behavior from 5 years to 15 years. And they have high-risk factors and low protective factors. The scores went up. They got worse in time. But then even if they started with high-risk factors, but then with the high protective factors, look at the scores decrease over time. And even if they had low risk and high protective factors, okay, similarly, you have a decrease in behavior scores over time. So there's something we can do. We have to focus on not just the risk factors, but the protective factors to enhance these children's development. And I have to share this because I really like this study. This is in experimental study showing the effect of environment, epigenetics on outcomes. And these are mother rats and pups. And here is we call it the silenced DNA after methylation. And here's your active DNA, okay? And if you look at maternal care, the high licking behavior of rat, if you've seen these rats born and the mother licking the rats, that's because it's related to the active DNA, okay? So what happens is the moms with the high licking behavior, as I said, high maternal care, have actually low methylation or the active DNA. If you cross-foster, okay, if you have pups from moms with low licking behavior and cross-foster them to the mom with a high licking behavior, high maternal care, that those pups born to the low maternal care moms will actually have their DNA have the activation of their DNA or demethylation of the DNA. And so they develop that instinct of high licking behavior and they transmit it to the next generation. So it is important that we promote that bonding right from the early age. So I would hope that we look at the child, not just the child, but that the mother's mental health is going to affect the child. But do we have to deal with that in order to promote the maternal-infant interaction, the attachment, and continuing caretaker involvement, even if we have all these issues in the community or in the neighborhood? Because every child is one caring adult away from a success story. So for clinical implications, policies, we focus on maternal treatment and beyond the neonatal period, beyond neonatal abstinence syndrome. We have to enhance child development. The prenatal exposure can be aggravated by environmental risk, but it can also be mitigated by protective factors. We need to explore interventions not only to minimize the adverse effects of prenatal drug exposure, but also to enhance protective factors. If we don't do this, then we're going to have a sinking ship. It will really take a village to address the issues of neonatal abstinence syndromes and their families. Thank you.
So we have a few minutes, and we're wondering if you have any questions for Dr. Bada. Perlu?
Have you studied the effects of grooming in as a treatment for babies born exposed to opioids?
We are actually trying to promote that in our unit. But there are studies that are showing that actually these babies do well and you shorten the length of stay. Now, what happens after that is still a big unknown. The other issue, though, with rooming in, I think if we can just promote it initially, because we have to start from the beginning, if we can promote it, even if the mother, I'm thinking here, if there's any time that that mother may change her mind and would actually say, oh, I need to get sober because of this beautiful baby and my holding this baby, that would be a good chance for us. That's an opportunity for everybody. So I would promote it even if she was not on treatment program and she's seeing the child for the first time. But then with that, though, we have to have a plan of safe care and make sure that the baby's health is really looked after when baby goes home. And even if the baby is not going home without mom, I think that bonding in there is important, and we have the law that we have to really address permanency. So that would help the mother with her treatment, and she can have her baby hopefully in a few months, 6 months, and especially she has support at home. So we really investigate everything surrounding that family.
So I'm gonna invite, I'm gonna invite Dr. Feinberg, and if you both would mind sitting down, then we can have questions. We have about 10 more minutes, so if you have questions for either one of them, we're happy to take those questions. I guess we'll just have to pass this back and forth, whoever.
You guys both mentioned testing the mothers for either opioids or Hep C and several things. Is that something that you have to inform them and get consent to do that, or is that something that can be in any protocol for prenatal care without consent?
Well, it's already practice recommended to screen the mothers for syphilis, GC, chlamydia, all the STDs. Now, HIV, we test them and we inform them that we're testing them. I think there's a way of saying, and I know people would be hesitant to, you have to get permission, but if you inform them that you're going to test her, then I think that's okay. The other thing, from the pediatrician standpoint, my thinking is, if I need an information to treat that baby, then I'm going to tell that mother, I need you tested because it's for the benefit. The only way we can treat your child.
And actually, the laws in most states regarding, for example, HIV testing have really dramatically changed in the last few years. So they used to be quite complex. Most states, had to get written informed consent. You had to do pre-test counseling. You had to do post-test counseling. Now in most states, all you need to say to the person is, we're going to screen you for XYZ and HIV as part of routine care. And once people consent to routine care, then you can do that kind of testing. Now, opioid testing isn't typically part of routine care, but I agree with Henrietta. It's absolutely for the benefit of the baby. And most women really want to do what's best for their babies. So, usually you get their cooperation.
Dr. Bailey, and then you'll be second.
I just want to respond to that.
Oh,
Is
okay.
what St. Elizabeth is doing. As far as the prenatal care, the women are tested in their prenatal labs for HIV, as well as all the other standard prenatal testing. But St. Elizabeth does universal drug testing. So every mom that comes in to deliver, they do receive universal drug testing upon admission for labor. Right. So that is part of St. Elizabeth's policy.
So as I mentioned before, all the hospital systems in Metro Cincinnati, including St. E's and Southeast Indiana, are part of this health collaborative. And since September of 2013, it has become routine to test every mom coming in for labor and delivery for drug exposure. And we have been trying to also get the health collaborative to then test the moms who were positive for drug exposure for hepatitis C, which is tricky because you have to link the result, which is part of the mother's chart, to the baby's chart, and that's a very difficult thing to do in the day of electronic medical records and everything else. And I don't know where that happened, because I went to West Virginia, you know, after we made this proposal. So I thought it had taken place in 2016, but it hasn't?
It's on the radar.
On the radar, right. Right. Because, you know, babies with hepatitis C, they're not as likely, as far as we know, to develop cirrhosis and end-stage liver disease as babies with hepatitis B, but some of them will. And, you know, what a tragedy, be 20 years old and need a liver transplant. I mean, so the earlier the pediatrician knows that, that baby can be monitored and that baby can be cured.
Dr. Bailey has
Yeah, thank you both. Very informative presentations. My question's actually for Dr. Bada. You talked about NAS scoring and the Finnegan, which is obviously kind of our gold standard. Have you started in Kentucky using the new Yale Functional Scoring Assessment, the ESC? We've kind of debated it in Tennessee of whether to start looking at that or not.
What scoring was it?
The ESC, the eating, the sleeping, consolability, it's fairly new out of Yale.
No, we're not
Okay.
using it. I've been working with Dr. Finnegan, and you know, that was in the 60s when she developed the scoring system. And knowing then how doctors were or neonatologists were, they were at bedside all the time. And she painstakingly observed all these kids for all these symptoms, because in her mind, she was thinking, I don't want to miss anything, you know? So that's why she ended up with a 21-item scoring system. And if you come right down to it, it's what we call a scoring system based on clinical data, or the old word by the statistician is, they call it clinometrics, and that's very different from looking at psychometric properties. And I think there's some camp that would look at the Finnegan scoring and evaluate it for psychometric properties, and you really can't get it. So, you know, it's like trying to get the psychometric properties of the Apgar score. So really the Finnegan scoring is really more a clinical tool, and that the items are not really interrelated. They may all appear, but you know, just because the baby is stiff doesn't mean that the baby is going to have loose stools. So that's the you know, the nice thing about the Finnegan score. We have actually done a shortened scoring system, just published recently, but even if I was part of it, I'm not recommending it, because we still have to validate it on a prospective study. We looked at 44,000 Finnegan scores in 2 institutions, and that's how we derived with the score. But we still need to do a prospective study to really see whether it's as good as it will detect the same issues as or treatment threshold as the original Finnegan score.
Thank you. We have another question in the back.
Yes, thank you. I'm wondering, you mentioned something about the cognitive and the behavioral deficits that these kids are coming up with, and I'm wondering if you could elaborate on that just a little bit about what those look like, and also whether or not we're doing anything as far as education programs to help teachers and education personnel to know how to deal with these kids when they do get into school.
If we look at the studies on outcomes of these kids, there are several studies during when we started the methadone treatment of mothers on heroin who were addicted to heroin, and basically showed lower cognitive scores, either Stanford-Binet or the early part with the Bailey, and then also the lower language scores. The problem with these outcomes, too, is that you're looking at one domain, okay? And then if they have, and the behavior outcome is also, they all have attention problems is the big thing that we're seeing with opiate exposure. So with, you know, there's an interrelationship between cognitive functioning and behavior. They have lower cognitive functioning because of the behavior, or are they having behavioral problems because they just don't understand? So I think it's an area, I think, of, you know, to be looking at, to study. And I tell you, even these little babies, I mean, I know who are the psychologists, experimental psychologists in here. We have looked at tracking, eye tracking, looking at showing them faces and all that, and make changes in these faces. And even newborns at 3 days of age can actually recognize difference between the normal face, quote unquote, versus the ones that we change the faces. So I think they're capable of really developing from the cognitive standpoint, but we have to address all the other issues of behavior and the issues with the families, which Dr. Feinberg has been talking about.
So I think that's a great question. I actually met with the dean of our School of Education a couple of weeks ago to say, this is a moment to really do important research on how to teach children who have these problems. You know, they're obviously going to need some sort of IEP, but you know, there may be some commonalities, some specific things that we need to do. And so I think that, you know, I agree with Henrietta, it's complex, but that doesn't mean that we shouldn't be, you know, investigating how best to take care of these children, because in some of these communities, it's a lot of children. I mean, and I think the potential for, you know, the schools to be fairly overwhelmed by this is significant.
We have one more question?
So actually,
Oh. Sorry. Okay, we'll do quick, okay, and then we'll come back to you. Go ahead, yeah.
I guess my big concern is we've talked a lot about infants who we diagnose with NAS, but what about all those infants that we didn't diagnose, went home with mom or to foster care, and who were opiate exposed? What do we know about them?
Very little. We know about them if, for example, there's some doing we also have a SUID registry, and we are mandated to review deaths in the first year of life. And there will be those deaths with unsafe sleep or deaths from abusive head trauma. And these kids actually did not have symptoms, but we knew that the mother was exposed to, the mother was using opiates during pregnancy. And I think what's really unclear is when these babies are going to have withdrawal. They may not have NAS in the first 3 days or 5 days of life that we are observing in the hospital, but 2 weeks later, they'll be fussy, they'll be jittery, and they'll have all this irritability and terrible cry, and you know, the parents just won't be able to stand it, and you end up with a bad outcome. That's what I'm saying. We don't know if how symptoms affecting outcome, with no symptoms, how that's affecting outcome, not to mention all the issues surrounding that family, the home, the environment that the child is, you know.
We have one last question in the back.
Yes. So my question kind of fits in with some of this. So let's say if everyone's sort of recommending screening for everyone, do we have, I mean, I don't think we have the necessary ability then to do what we need to do when they screen positive, right? If all of a sudden there are going to be all these other babies, or what happens next? Because I think school's important, but intervention can start way before they get to school.
Agree with that 100%. But I think that is, let me put it that way. I think from the public health standpoint, that's the beginning of knowing whether there's exposure or not. And if you know there's exposure, then you can at least look at the resources that the mother and the baby would need and start with that. And then we're also obligated by law to have a plan of safe care for these children. And I think that's one thing that we are doing or we're working on, because it's difficult to have a plan of safe care when you're dealing with the mom and the child, and then their need for the resources in the community and everything else.
I think one of the ways to deal with this is, children who are born premature, they get all of this aftercare and oversight, occupational therapy, physical therapy, because absolutely things have to start happening immediately. You can't wait till they go to kindergarten. I'm just saying once they get to kindergarten, you have to figure out how to deal with it. And I think we need a parallel system for these babies and these families to ensure that people get parenting skills, you know, that there's observation of what's going on in the home. I mean, to me, this seems very much parallel to all that wonderful work we do for preemies, you know, that helps them mature, you know, eventually reach the right milestones. And I think that these families and these babies are going to need that level of support.
Thank you. We're going to have to...
Can I just add to that? In Kentucky, we have a home visiting program that's really known all over the country because of the results. And this actually involves home visitation and also observing parent-child interaction, teaching the families or the parents some parenting skills, how to recognize the child's cues. And with that, they also screen the mother for depression. And within our system, they can make referral to mental health, and they have a program that they can actually do home visitation while treating the also mental health, their depression, help the moms with their depression. So there are good programs out there. I think it's a matter of knowing where they are and how to get to them, and we'll just have to do our best with the resources that we have.
Thank you so much. Please help me thank Dr. Bada and Dr. Feinberg. It sounds like we have a lot more research to do, right? It sounds like there's some things that we don't know and that we need to get some more work on. So we are going to take a break now, and on your tables there are some Post-it notes, a pile of pink Post-it notes and a pile of orange Post-it notes. And we know that when you are sitting here and hearing a lot of information, that you need some time to process it, talking to other people, writing ideas down. So we've got 2 questions that we'd love for you to respond to now or throughout the day. What are the advantages and obstacles to a research consortium? And what is the most critical research need as our region faces the opioid epidemic? If you are an academic, we'd like you to answer that on an orange Post-it note and post it back on the back wall. The questions are posted back there. If you're a community practitioner, we'd like you to write your ideas on the pink Post-it notes. There's markers on your tables as well. So we'd love to have your ideas, talk with others, write your ideas down so we can capture those throughout the day. So we'd like you to take a break now, go to the restroom and some more to drink, and be back here. We'll start at 10:12 or 11:12.